So we're going to start off by talking about our instruments. This is a four instrument set from MedSync, and it has our four essential instruments. It has a needle holder, take off the tip. It has a jeweler's forceps, a straight scissor, and a dilator. Let's talk about the two types of forceps you have. One is not a forceps, one is dilator. So this is the forceps, this is the dilator. You can tell for these two instruments because this has a curved body and this has a straight body. This goes in, well, this can hold the vessel. This can go inside the vessel. This would just hold the vessel. This can hold your suture. You can hold sutures with this, but this is specifically tailored to go inside vessels without causing intimal damage. You use them at the same time. You hold the instruments in the same way you would normal instruments, normal forceps. The body goes above your index finger. So not like this, but like this, and this one at the same time. The key to the microsurgery is that everything is between your index, thumb, and middle. You hold it closer to the tip than towards the end, that you have control. And the movements are really in your fingers, pretty much not in your wrist. At best, at worst, in your wrist, definitely not in your elbow, so your elbows stay against your body. At the same time you're using one of these instruments, you'd be using your needle holder. Your needle holder is blunt tipped, does not have a ratchet, so it doesn't lock. So you have to have good purchase on the body of the needle holder. If you let go, it will open. And then your typical microset will have a straight scissor for cutting sutures and a curved scissor for cutting tissue and dissection. So now we've talked about the instruments, let's find our chicken vessels. So if you get a chicken thigh with bone in it, you'll find there's a wider side and a thinner side. On the wider side, just under this muscle, if you lift it up and free it with your finger, it's the quickest way, you will see a collection of tissues. These are your neurovascular structures. There'll be a vein, an artery, and a nerve. Just zoom out a little bit so you can see. And that's what you want to dissect. So you get your forceps and you get your scissors. You can get the main size, but I find that with this you can just peel, 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 peel. You just want to get a segment of these structures in a run. Push those structures down and lift. Now, it will go all the way to here, but I only want to operate in this field anyway. So in terms of dissecting, it's the same as when you do macroscopic. Don't force tissue planes, let them become apparent to you. So you hold up the tissue and you can push down what's gonna fall away. If it's not falling away, you can assume, so for example, in here, this isn't coming off as easily. So I can assume there's vessels coming in. Let me see if I can increase the light in there so you can see that better. I think that's better. So I'm just going to work my way. So I've got started down here, pushing all this down, letting it all kind of express itself. Where it's not falling away, you can see vessels becoming apparent, little branches and tributaries coming off. So this will either be a vein or an artery. I think it's likely to be a vein. Why? Because it's thin-walled. Arteries have thicker walls because their media has smooth muscle in it. And then somewhere in here, there'll be a nerve and an artery. So that's the nerve, that's the artery. So we want to define them a bit more. Let's be a bit systematic. Let's go to the next structure in line. Let's hold it up by the adventitia. There'll be branches and tributaries coming off to supply the nerve, the vasa nervorum. You can just gently tease it all off. You want to tease it off on the front, on the back. If you were raising the flap of tissue based on this artery, you'd clip off any branches going deep. But I think in terms of dissection, it's nice to do a dissection where you leave all these tributaries in continuity rather than just cutting them off. In reality, you'd either use a bipolar and cauterize them, monopolar and cauterize them, or put clips on, liga clips on them to stop them from bleeding when you cut things. You just want to do the same thing for the nerve. This is just a bit of fat. And if things aren't giving way, you can assume there are vessels in there. If you can see that there's nothing in there, you can then cut, cut, and cut. But you have to be sure there's nothing in it. If you're not sure, cauterize it or clip it. And so then I freed a nerve, an artery, and a vein. In terms of the nerve, what you tend to find is that there are actually two nerves in there, like in the sciatic nerve of a human. So when I cut this, two bundles will become apparent. It will be the common perineal and tibial nerve. So with the human sciatic, you can do a fascicular repair, where you repair the fascicles in itself, the motor fascicles, sensory fascicles inside, and then you do the epidural repair on the outside. So now we've dissected our structures. The artery, just want to make sure it's really, really clean. Times where you're a bit more cautious, maybe do it under a microscope, is where they've had radiotherapy. Vessels are far more friable. They bleed a lot more easily. So you have to be a bit more cautious. So this is the nerve. I'm going to cut it in one cut, ideally, and free it. And you can see the epineurium is here on the outside, and the fascicles are in, bulging out. And this would be like how you'd expect. This is the reason I use chicken thigh is because it simulates the size of a digital vessel a digital vessel and digital nerve in the finger. It's about the same size. So for microsurgery, we use monofilament sutures typically, and typically they will be nylon or any variation of nylon like SNT or any brand. I think I have a nino here. Let's see how that works. So for nerves, you do a coaptation. It's not an anastomosis. So you coapt the nerve. You want to align the nerve like a jigsaw. So you see how my straight cut is not so straight. Kind of goes oblique this way and oblique that way. You want to align them. The other way of knowing the alignment of your vessels is that, and when the vessel is alive, there'll be a small network of vessels running on top and around the nerve. That's the vasa nervorum, and you want to make sure that they're matching on each side. With digital nerves, so in the finger, where they're this size, if you get an 8-0 nylon, you only need to put 2 to 3 sutures maximum to align it. So I personally tend to do the back wall first. You're just stitching the epineurium. You're not stitching into the core substance, just the outer lining. You need to put traction on. Keep the traction. This hand doesn't move. Go in at 90 degrees and let go. And then pull it through. Ideally, you want to mount it how you want it to start with. And then you carry on. Again, put it in the right orientation for yourself. Traction, enter at 90 degrees, and you rotate. You can push through in more than one. And then you rotate. And it's small maneuvers. I'm going to zoom out a little bit so you can see my hands are doing. And what you'll see is that they're not doing much. So my field, my hands are just staying here, and it's just my fingers moving side to side. That's it. But we'll go back. My instruments are just an extension of my hands. The key to microsurgery is that you do not want your hands to cross. And that's where the macroscopic suturing and how you do macroscopic surgery is really relevant. So you see when I say you suture, I say push your finger rather than moving your whole body across. Just use your finger. We take this one step further in microsurgery, and normally what you want is the position of the short end with no suture and the position of the long end with needle, sorry, the short end with no needle and the long end with needle to alternate. So this needs to come this way and this needs to come this way. You always wrap the needle end around the needle holder in normal suturing. In microsurgery, the needle holder and forceps are interchangeable. And the instrument that's going to bring the short suture towards it is the instrument you wrap the needle suture around. So on this instance, this suture needs to come this way. Therefore, I'm going to wrap this suture, or this end of the suture, around the needle holder. Take the suture and pull it just tight. Now, where's my other end gone? Just under there. You want to leave the short end somewhere where you can find it. And now you use the forceps to wrap around the suture, because this suture now needs to come this side. So I'm just going to go, like, tips are always up. So they're like this rather than like this, because then you can just, then your loop stays on the instrument. I'm rotating my forceps a little bit to grab this suture and then pull it through. I'm just caught on there, so I'm just letting go one instrument at a time. I don't let go of both. My knot's a bit loose, so I'm going to do the same trick we do with macro suturing. I'm going to pull the short end until it's approximated, and then pull the long. And then alternate. You bring the suture to the instrument rather than the instrument to the suture. And it's just small maneuvers till it's just tight. If you needed to put another suture in the back wall, I often will cut the short suture first, the needleless suture first, because if you lose this suture, you'll never really find it. But if I cut this suture first, I know that my needle end is still attached, and I'll have it in my hand ready to go. Now, I'm going to do something ridiculous and try and carry on suturing with it. Ironically, it's easier to suture with a shorter end than it is a longer end. So my orientation is correct. So now I need to put one here and one somewhere over there. So it's an epidural stitch traction. Enter at 90 degrees and just rotate. It's a superficial bite. Push. Unlike macroscopic suturing, which is I think something I learned quite late on, micro suturing, I think it's better practice and you have better flow if you just keep taking it with the needle holder rather than pushing it through with the needle holder, grabbing it with the forceps, and then mounting it again. I think you don't want to overhandle the needle. So if you don't need to grab it with the forceps, don't. So I think yesterday I was saying how to stitch fast. Take it with the forceps, mount it straight away. I don't think that really works so much here, but sometimes I'll do it. So if I'm stitching in the neck or you're deep. Okay. Yeah, I'll zoom out on the next one. If you're stitching in the neck or in the chest or in a deep cavity, you may want to grab the suture so that you don't lose it. You often have to wipe your instruments because they get bits of tissue in them, and when they get bits of tissue in them, it becomes harder to grab your suture. This is why I said it's easier to do it with a short suture because then it's right there. This is a 9-0. And you don't want to over tighten it so it overlaps. You just want to approximate it till it touches. Leave a little bit of length. Again, I can leave this one a bit longer and I'll use it to rotate the nerve on my final stitch. Okay, you want to see my fingers and what they're doing. Okay, so I'm pulling my short suture towards me, and allows me to see the far side, and I'm just going to place the suture across in one. Superficially, because it's just epinurium. Try and keep the other hand still whilst your suturing hand is doing the work. And through. So now, this short suture over here needs to come over here. So I'm going to wrap it around this instrument. I'm going to wrap the needle end around this instrument rather than this. So this is now my needle holder, if you want to look at it like that. So my loop has come down here. I've wrapped, because my shoot is short, I'm just doing a reef knot, which I know is less secure than a surgeon's knot, so I just can't disrupt things as I'm tying. To make it easier to grab my suture, I'm going to turn the needle holder upside down because my suture is down there. And then I don't have to work so hard. And then my final one. And tie. Again, I'm going to cut the short end first so that my needle end is within my surgical field, visible, and I haven't lost it. And I can park it straight away. The one thing you don't want to do with your micro instruments is dab the instrument into the surface, because then you blunt and damage the tips, and the tips will diverge. If the tips diverge, you will not be able to use your instruments. So if you need to readjust, just shuffle it into your fingers. I find if you keep your finger somewhere down here, you have more control. So that is how you do an epineural nerve repair. I wasn't rushing at all. I was being slow, if anything. It doesn't take that long. It's quite a quick procedure. If you find you have fascicles sticking out like a bit here, you can put another stitch in there if you want to keep it together, but I think it will be okay. So next, we need to go on to doing our artery repair. Takes a bit longer, but this is how I would do it. So once you've prepared, so let's say you're doing it for, reconstructive surgery, the vessel is in continuity and this is your recipient vessel. This is going to receive your flap tissue. You clean up the adventitia. Like I said, if it's irradiated, don't do it too much. And then you put your clamps on distally and proximally. Then you divide your vessel. And then you get your dilator and go into the lumen. I tend to find if you go in with one first and open it up, you can kind of shuffle it down and just twist. It opens up quite nicely, and then you can put both in if you need. You can see it opens it up quite significantly, I think. gives it a reasonable amount. You flush it, well, you now take off the clamp and see its flow. If it's not flowing so much, just flush it with Hepsal. If it's divided already, we'll have clot in it. You go in, you milk any clot out, you go in, dilate it, just twist while with the teeth open and pull it out. If it's not flowing, flush it with the heparin and saline, and then it should flow. You put the clamp back on. Same thing on the opposite side. So I've switched my instruments. So this is where you find that you have to be a bit, what they say, ambidextrous. And both your hands need to work well. So it's a good excuse to play more games that have analog sticks. Whether it helps, I don't know, but it's a good excuse, isn't it? And then just rotate. Again, if at this point, take your clamps off and flush if it's divided. This is also the point if you're doing it in finger trauma and you're doing it with a tourniquet on the finger or the arm, the patient's awake, put the clamps on, take off the tourniquet. The main vessels won't bleed because you've got them under control of the clamp. And you can check if you've got flow before you do your anastomosis. You can use a double end clamp that will keep it together, and you can turn it, or you can use a single edge clamp. The choice is yours. For this size vessel, I would use a 9-0 or a 10-0. If the finger is already pink and I'm just repairing the vessel, I'll probably use a 9. If it's not pink and I really, really want to be really, really scrutinize my work, I'll use a 10. So that I have to really control the sutures. So the key to this, I then have my dilator and my needle holder in my hands, is you have to do the back wall first. I find, well, the choice is yours. Some people triangulate and do, 2 points first in the top and then rotate it. I prefer just to do the hardest bits first, which is the back wall, and then come around the front. That's my preference. So I do slap bang in the middle at the back, and then I do either side of it at the back, and then I do the sides and then I do the front, the sides proper and the front. Okay, so you can put your forceps in the lumen, open and go in between, rotate, push it down. You then need to go in the opposite side. Don't pull too hard, but pull in line with the structure. Make sure your suture's on the other side. But this is why I said it's easier to do when you've got a short suture. So my suture ends over there, so my other end needs to go on the opposite side. The easiest way, I think, to do the opposite side is to put the vessel dilators in the lumen, go in, and rotate in between. That way, you're through. And pull. Now this is really key. Put the needle somewhere where you can see it, but out of your way. But put it up there so I can see it, but it's out of my way. Same principles apply. The instrument that brings the short end towards it is the instrument you wrap the long suture around. So I need to bring that suture towards my needle holder. So I wrap the long suture around my needle holder. Make it a bit shorter. I'm going to turn my needle holder down. And in macroscopic suturing, I always say that thing where you just push the suture. Same thing applies here. Go near where you want to suture, tie your knots, push the suture forward and let it make the loop, and then wrap it around. Keep the thread behind, grab the tip of the suture and tie. Just till it kisses, then leave it somewhere where you can find it, and then go to the instrument and continue. This rest of long thread should not be in the way of where you're tying. It has to be behind. Otherwise, it'll get caught in the way. So this suture here should never be in between. It should always be out of the way. And tie. Bring your needle holder closer to the knot site and tie so you have the right amount of tension. You may have to wipe your instruments, otherwise you won't get the grip. And then you go again. Bring your instrument closer. As I said, just till it's finger tight. You can leave the short end longer so that you can use it to turn around on. And then if you're getting your assistant to cut for you, hold it up, leave a good few millimeters of length. You know where your needle is, it's over there. And like I said, this is where I do all of the back bit first. And then one there, and then one on this side. So I'm going to do this side first for me. Actually, I'll do the far side. The far side will be harder, so let me do that now whilst I have the access to see. I'll do this zoomed in, then I'll zoom out a little bit. So you want to turn it towards you. If you go in, but you need to make sure you haven't caught the back wall. So your assistant ideally would flush some Hepsal in now. Don't catch the back wall. See the tip, which I can. I know I'm not catching the back wall. And I'm going to do it in two because I can't, this wall is a bit flush against the back wall, so I want to make sure I do not catch the back wall. I'm going to pull my suture through now a little bit so it's not so much work later. I'm going to use my needle to make sure my vessels are apart and going in the same space opposite. I'm going to keep a hold of it here, so I only move one instrument at a time rather than both, and then pull. It gives me more stability. Now that bit of fat is going to have to come off because it's in my way. Put the needle somewhere secure first. That little bit of fat that came floating in has to go out. Otherwise, it'll get caught in the lumen, you get a clot in there. And then now we need to tie. So remember, you've got two short ends. You have to know which one's which. I know it's this long, the slightly longer one, but I'm going to shorten it to make it easier. That short suture needs to come here. So I'm going to wrap my long suture around my dilator, this one. As I said, this suture should never lie, that long end with the needle on it, should never lie between where you're tying. Otherwise, it gets caught in the loop and you won't be able to make your surgeon's knot. Bring your needle holder closer so that you can tie with the right amount of tension. As I said, you also probably will need to dab your instruments and just position yourself optimally so you can tie. Turning the needle holder around because my suture is down there to make it easier to grab. Keeping my suture behind so it doesn't slip off the needle holder. And tie. If you have any questions, do feel free to comment. Pass the suture to the other instrument. Make sure the remainder of the suture is not in the way. Go under the suture, not over, otherwise it'll get caught in the way, so under. And tie. I'm going to cut that suture with the needle end on it last because it's got the needle on it and I want to know where it is at all times. Remember to wipe your instruments regularly, otherwise you won't be able to grab your sutures very easily. I'm wiping them now, but you could also just fasten to your scrub nurse to do, because if you're doing this, you'll have a scrub nurse. I hope. And cut. And hopefully they're paying attention on the screen if you're using a microscope or with your loupes. I'm currently doing this with loupes because the camera is my is what the other way of using it, practicing. So now, this would be a good time to flush with heparin saline. I'm going to do my side of the side. I'll zoom out a bit so you can see my hands rather than focusing so much on the micro as such. So my hands stay close. Get that out of the way. I'm going to go in the lumen, rotate it to myself, rotate it away from me. Go in. I see the tip before I go across, and I might be able to do it in one continuous. I can, so I will. And I'm just going to put some counter traction on the opposite side. Not moving this one whilst my needle hold is moving. Putting some counter traction on and rotate and pulling my needle till my short suture becomes as short as I want it. Placing my short suture nearby so I can see it, but it's out of the way. And then the tie. So I'm using 3.5 loops, but you can do this with 2.5 loops. I think it's slightly harder to do micro with 2.5 loops. Easy with 3.5, but you can definitely do nerve with 2.5. And you can definitely dissect perforators with 2.5. I think it's possible with a good size. If it was this size, yeah, you could do a 2.5. And pass the suture. But the other way to do it is just use a smartphone and a camera stand, and you can practice as if you're in a microscope. But if you have loops, then absolutely just do it with loops. I think one of the key things you need to practice with microsuturing is the backhand maneuver, suturing in reverse. So with the needle in this configuration, point this way. Probably even can't see it, but the point is over here, the swage is down here, and suturing that way rather than suturing that way. Because that can be that's the first stitch I often do first, because it's the hardest technically and the hardest positionally, because it's the back wall. So it's good if you can do that. So you always have this decision when you come to the anterior surface, one or two. If you need two sutures, do them in continuity. So that way you can see the lumen. If you need two sutures, I can get away with one with this suture that I'm using right in the middle. But if you need two, let's do two maybe for the sake of teaching. You do two because that way you haven't closed the space off before you've tied your knots. So I'm going to go in close to my previous one because there's not a big space. My vessels are in, so my vessel dilator is inside. And see the tip. I can see it there. See the tip. And then pull. Now I'm going to place my second suture without tying, in continuity. Vessel dilator inside, stitch in between. See the tip, so as in don't make sure you're not in the back wall. Lift up. See the tip come out and not in the back wall. Again, this would be a good time to flush some heparin saline in. Pull your suture through. And then make your loop slightly longer. So you can either tie it, let me put this on the far side, whichever side is your second bite. You can either tie it to the loop directly, or I prefer to do it in two. So I cut the loop in the middle, and then I have a long end and a short end for both knots. Flush with Hepsal beforehand. Make sure you're happy with you're not on the back wall, and then tie. So for this one, I haven't got a needle on it. So I'm gonna make this side my short end, this side my long end, that end my short end. So I'm wrapping around the dilator first. Lift up so you come off of the back wall. Don't catch anything. Passing my suture to the dilator now. Wrap around the needle holder, tips down because it's easier to grab the suture. I do think the more you practice microsurgery, the more you practice suturing, the more steady your hand may be, because I've probably had an unholy amount of coffees today, and I would say I'm fairly minimal on the tremor, which I have when I even do macroscopic suturing. So I think it's very variable, but I think the more you do, the less tremor you get for sure. I know we were talking about that yesterday. But the other thing is position. So my forearms are planted on the table. My elbows have not left side of my body. And I'm in a good, comfortable position surgically. And everything is about control and take your time. I'll zoom out so you can see my hands for this last one. So my needle end is here. My short end is here. So I need to bring the short end over here. So take the long end with the needle holder, make my short end short, wrap it around the dilator. If you have an assistant, they can pass you the suture to make your life easier, but I don't. So you try and leave that suture somewhere where it's easy to grab. Make sure you flush your surgical field when you're flushing with Hepsal so that everything stays a bit moist and easy to, and less sticky. Bring your instruments close to where you're tying. Don't pull too hard, otherwise you'll fracture the suture. And then the last one. Okay, so I'm going to do the same thing. I'm going to cut my short suture first. I'm going to cut my first short suture. And then I'm going to cut this suture with the needle on it. And I'm going to park it. Like so. Okay, so then what you want to do, you can either make an arteriotomy and flush it, or you can cut it out like this. And then what we can do is open it up by doing a longitudinal incision and assess placement and position of sutures. So let me pop that back here. And let me lay it in the orientation it was supposed to be in. And then we can look together. Oh, the light's a bit bright on the wet stuff, isn't it? Let me pop it on my finger and let's see. A bit difficult to see on the camera, but what I'm assessing is the interval, the space between the sutures, which I think is fairly even, and whether the bite from one side goes straight across to the other, which they do, and are the layers of the vessel approximated? Yes. And when I cut it, I could put the vessel dilators down the whole thing so I didn't catch the back wall. So I say it was a good anastomosis. And that, if you want to practice more microsurgery, the other thing you can do is you can do vein graft into that space. The difference with the vein, though, is that it's got a bigger lumen. So when you dilate it, you'll find it expands. So you take closer bites on this side and slightly wider bites on the vein side if you've got a discrepancy to bring it in. If it's like that, to bring it in, you take slightly more spaced bites along the vein. Have you got any questions? Yeah, I can. Always take out of the needle holder parked. Um, I mean, so this is the forehand grip, and then backhand. It's interesting. You can do that little swivel trick even with microsurgery. It's your fingers are the same, but you are relying on the rolling the needle. So is the pointy bit is that way, but what you want to see actually is my hands. My fingers are the same, but the rotational movement is this way to make it go through my tissue. So if I want to stitch through this with the needle this side, I have to rotate this way. Whereas if I'm going forehand, it's I'm already rotated to start with, and then I enter. Yeah. Any other questions? So the backhand rotate as I go in. The forehand, I'm already rotated before I start. If that makes sense. Um, so of course we have the microsurgery videos on the wound on the vid on the YouTube and the MedSync website. So you can look at those. Now that's the wound. If the skin is hanging by a thread, suture back, will the skin be viable or become dead? If it's hanging on by a thread, depends where it is. Realistically, if it's not, if you rub the edge and it bleeds, then it bleeds normal blood. It's viable, so you can stitch it back. Often on the leg, the lower leg in elderly patients just put the skin back because it will heal quicker than if you take it all off and create a bigger wound. What will survive, and what won't will slough off. Another body part, if it's on the back of the hand or the forearm, and you have enough laxity to close it without it, and it's just a straggly bit of skin, just cut it off and stitch the thing closed. It'll give you a neater wound and it'll heal quicker. Fingertips, typically you put them back. If you can't put vessels in, you may be putting it as a composite graft. How to close a port site. See, that's not something that I typically do, but with port sites, it's the same thing, isn't it? For general surgery, they close the deep tissues on block with a PDS and then close the skin separately. That's how they do it. Um, but that's not something that I usually do, so I'm afraid I'm not going to give you the tips on that because that's not my area of expertise, but they do it in two layers. Mass closure for the deep and superficial for the top. Great. So